A very good evening, ladies and gentlemen. Team Dentist Channel Online welcomes you to yet another live webinar. New day, new webinar presented to you, published to you, and brought to you by Dentist Channel Online, India's most active dental media and dental news, information, everything related to dental company. My name is Ruben Lobo. I am your host for this evening. As you can see, today we have with us one of the most dynamic dentists all the way from Mansarovar, Rajasthan. He is Dr. Puneet Bhargava. Dr. Puneet Bhargava is a well-known academician, clinician who's been practicing dentistry for the past 21 years. I'd like to give a short introduction about our speaker for today, Dr. Puneet Bhargava. Dr. Puneet Bhargava is a graduate of KLE Institute of Dental Sciences, Belgaum, and who happened to complete his master's in BDS in the year 1998. He earned his master's degree in oral medicine and maxillofacial radiology from SDM College of Dental Sciences, Dharwad. Currently, he is also pursuing his clinical master's in immediate functional loading implantology from Germany. Dr. Puneet has worked as a professor in the Department of Oral Medicine and Radiology in the Government Dental College, Jaipur, and NIMS Dental College, Jaipur. He has various international and national publications under his belt and has also given numerous lectures at various reputed forums. At present, he is successfully running a private practice in Mansarovar, Jaipur, which has gained good reputation in the last 21 years. Presently, he is into exclusive oral medicine practice and is treating patients of oral cancer before and after cancer therapy at his clinic. Dr. Puneet, Dentist Channel Online welcomes you to our platform. The stage is set and it's now time for you to present. Without much further ado, ladies and gentlemen, presenting Dr. Puneet Bhargava live. Thank you.
Thank you so much. Am I audible?
Yes, sir. Thank you.
Yeah, good evening, my seniors. Good evening, my seniors, my colleagues, and my students. First of all, I want to thank Dentist Online channel for giving me this opportunity to present this topic on the very special day, the No Tobacco Day. Guys, people diagnosed earlier with oral cancer are not only more likely to survive, but importantly also to have better experience of care, lower treatment morbidity, and improved quality of life. But only compared to those who are diagnosed late. But why late? Do a patient need this type of life? And not only the patient, do this family member, his family member has to live in the dark shadows of cancer? No. Do they also have do they also have to face the devastating effect of cancer on the family as a whole? No. So the oral cancer is one of the most life-threatening of all the diseases and may be preceded by oral potentially malignant disorders. These disorders show visible clinical changes in the oral mucosa in the form of white and red patches, which may resemble each other. So the proper understanding of these disorders is necessary, which in turn helpful to make the appropriate diagnosis and the patient management. So coming to the two categories of these pre-malignant disorders is that the precancerous condition and the pre-malignant lesion. Basically, condition denotes a generalized state of body, and the lesion denotes morphological altered tissue. So there's a difference between both of them because the generalized state of the body here involves as a part of whole body. We cannot say that a condition is a lesion. Lesion is a just morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart in the mouth. So what are the precancerous conditions? They are basically oral lichen planus, oral submucous fibrosis, Plummer-Vinson syndrome, chronic hyperplastic candidiasis. Other very rare to find is disc keratosis congenita, discoid lupus erythematosus, syphilitic glossitis, which we usually don't see now and very often. And then the precancerous lesions, leukoplakia, actinic cheilitis, and tobacco pouch keratosis. So lichen planus, as the name suggests, it is a common chronic immunologic mucocutaneous inflammatory disorder that affects the skin. And the most important thing is mucous membrane of the squamous cell origin. That has to be present there. It is characterized by T cell mediated damage to the basal layer of the epithelium. So the immunopathogenesis basically is still unknown. It is attributed to the higher levels of anxiety and greater depression. The contact hypersensitivity may be due to the amalgam, nickel, chromium, gold, copper, anything, cobalt. Mechanical trauma like calculus, trauma due to sharp cuts, filling crowns, poorly fitting prostheses. Systemic drugs like hypoglycemics, antihypertensive, antimalarials, ACE inhibitors. But when I say contact hypersensitivity, when I say mechanical trauma or systemic drugs, they are not causing lichen planus per se, but they are potentiating, they are precipitating the pre-existing lichen planus present in the mouth. So there can be attributed to the etiological factors. And then the viral antigens like human papilloma virus, human herpes virus. So they are also the etiological factors. Now, not going very much into the details of what is the pathophysiology, it is just that the endogenous factors and the exogenous factors, they actually combine to give the cell-mediated immunity, and ultimately they causes the activation of CD8 cytotoxic T cells, and ultimately leading to the apoptosis of keratinocytes and the disruption of the basement membrane. So what we can tell about the malignant transformation of oral lichen planus to squamous cell carcinoma, it is 0.4 to 3.7%. So basically, I'm sure that we all know from our BDS findings that the lichen planus is of 4 types: reticular, atrophic, erosive, bullous form, or a plaque form. They usually occurs in middle-aged adults. Female male to ratio is maybe 3:2. They are commonly seen in 5th to 6th decade of life, but maybe seen in 2nd or 3rd decade also. Out of all these 4, the reticular lichen planus is most common and present as indolent and painless lesion that is usually asymptomatic and consists of white striations, as you can see in this photographs, where the white linear lines meet each other. There is a final dot which is raised, and we call it as a bicam strias, and usually present on the buccal mucosa, labial mucosa, tongue, and gingiva. For example, this is a photograph of a patient showing the lichen planus on the left lateral border of the tongue. And then sometimes the reticular lichen planus maybe look like as a small dots, maybe sometimes confused by the photolysis granules, but they are actually whitish in color, and they are looks like a papular type of lichen planus. Sometimes present on the tongue, difficult to distinguish between the leukoplakia or the lichen planus because it looks like a plaque type of lichen planus. Patient complains that there is a deposition of the white patches present on my oral surface of the tongue, and he attributes that they say that I am not smoking, I am not having any habits, but still it is present. Sometimes a linear form of lichen planus present as like in this photograph. These are some bookish photographs taken from navel. So this is the annular form on the right side, and when the medicines were given, it actually gets healed. You will notice that the healing form of the lichen planus will always look like a blackish pigmented type. But when the reticular type of lichen planus gets undetected, untreated, or because they are usually asymptomatic, they actually accompanied with the as a erythematous area, and it occurs as inflamed areas with varying degree of discomfort. As you can see in this patient, there is a presence of atrophic lichen planus on the left buccal mucosa. Sometimes more root form of this atrophic form may be like the erosive lichen planus, which has a complication of patient has a complications, and it gives that it may be patient having a severe burning sensation and painful tongue while chewing the food. Bullous lichen planus is very rare to see because the bulla ruptures as soon as they are formed. Our colleague Babu et al. Sir has given one review over this bullous lichen planus. They have seen that there is a bullous present on the palate, and usually they rupture as soon as they are formed. Now, one thing I wanted to stress is like when I was telling about the contact hypersensitivity, and I was telling you about the mechanical trauma. There is a term called as Kovner's phenomena. Basically, Kovner's phenomena is the appearance of new skin lesions in the on the skin or in the oral cavity on previously unaffected skin secondary to trauma. So as a result, same happens in the oral cavity, like the gums, which are basically due to the continuous trauma of calculus. We are getting due to the continuous trauma of the calculus present in the subgingivally or supragingivally. This gives rise to the painful, friable, as you can see in this figure, fiery red, atrophic, denuded form of attached gingiva, and in this case, the patient is unable to do the toothbrushing also. So this creates a cycle of the plaque gets deposited on the tooth surface and the root surface, and again it will cause the lichen planus, that the Koebner phenomena, and the situation will keep on recycle. Then the other sides of external environments includes the hand skin, the skin of the hand flexure arms. Then sometimes on the glans penis, vulvar mucosa, nails also gets affected in the form of the lichen planus. Regarding the treatment, basically, asymptomatic reticular lichen planus doesn't require any treatment. It actually have you have to evaluate the lesion every 6 months, and if the patient is not, because the patients are not bothered in this type of things, they usually come to the complaint of dental pain or the gingival pain. But these type of reticular oral lichen planus, they usually get undiagnosed. But you have to evaluate. If you see these lichen planus, ask the patient, tell the patient that it has a pre-malignant potential, and you should always get it checked every 6 months. Mild to moderate symptomatic oral lichen planus basically are treated with the topical applications of triamcinolone acetonide, like 0.1% cream or ointment, and fluocinomide 0.5% ointment, betamethasone valrate. These are the ointment can be given to the patients. I will let you know how these ointments are delivered in the oral cavity. My moderate to severe oral lichen planus, basically 0.5 ml of triamcinolone acetonide, where you can give half of the injection of because the triamcinolone acetonide injection contains 10 milligram per ml suspension. So half the injection can be given, and if the oral lichen planus is severe form, acute form, then it can be um, adjusted with the 30 to 60 milligram of prednisolone once daily for 2 to 3 weeks. So the corticosteroids role play here in a very good amount, and it can be given as it is. Sometimes 0.1% topical tacrolimus ointment can also be given. It is available in the market in the form of, in the name called as Tacros. It comes into two concentration, 0.1% and 0.03%. And pimecrolimus ointment can also be given because it has been shown that it suppresses the T cell activation, and initially they binds to the cytosolic FK binding protein. So basically it suppresses the T cell activation. So the on the very onset of this application, after 24 hours, patient has given me a results that they have a decreased burning sensation. Now, this was a patient who has come to our clinic. Kindly notice here the white linear striations on the right buccal mucosa, on the upper labial mucosa, and the left labial mucosa. This patient was given, actually it looks like a reticular lichen planus to us at the first, but because patient gives a complaint that he has a complaint of burning sensation in the on the cheek, so he has been treated with 0.5 ml of Kenacort injection, which was given bi-weekly. And after the 3 weeks, patient has given a very good results, that he says that the lesions has reduced and the burning sensation has completely gone. Basically it depends on patient to patient. It's, you have to rate the patient according to the visual analog scale, and always give the patient, so like what does it feel like when the first day the patient has come, how much was the pain, how much was the burning sensation, how much is the discomfort while chewing the food, and now how he's feeling, because you have to read the psyche of the patient also. You have to get to the that root, that patient is able to take the food in the right manner. This was a patient who was actually troubled with brushing. Whenever he brushes the teeth, there is a bleeding in the mouth per se. And ideally, in these kind of patient, what we usually do is that we ask the patient to, in a mucostatic, we take a mucostatic impression like with the alginate, causing very less trauma to the patient while taking the impression. Um, asked the lab technician to form a occlusal splint, a very soft night guard or occlusal splint, so that it can act as a carrier for the ointment. I was telling you last time that how will we deliver those ointment. So the right way of delivering the ointment or the cream or these type of corticosteroid scheme is the take an impression of the patient and make a occlusal splint and put the medicine into the occlusal splint in a very evenly spread manner and ask the patient to wear it. Now this patient can wear for 4 to 5 minutes for 4 weeks, um, um, and this causes the duration, the medicine which has been dispensed in the occlusal splint, actually it gives a very good effect and it is not washed off with the saliva also. Though so many medicines like Kenacort medicine ointment is there, we all know the name is the Tess ointment and Kazakh ointment. Okay, so they have a aura base inside, but still I have seen that these type of things actually they wash, the saliva is washed off. So basically, the medicine should be given in the occlusal splint. Now, along with this occlusal splint, you can always give the patient 5 milligram. And this patient was given 5 milligram of prednisolone 3 times daily for 3 days, and then the dose was tapered down for further 6 days. So this is the result which we got in the patient after 4 weeks. Then this was the third patient where it was treated with the Kenacort ointment. Same, the occlusal splint was given, but because the lesion was very aggressive, the tablet Bisolone 30 milligram per day was given for the first week. Then it was tapered down to the 20 milligram per day for second week, then 10 milligram, and then 5 milligram thereafter. Plus, we have added one more drug here in this case, the tablet Vermisol. Well, tablet Vermisol is basically anti-helminthic drug, but the main function of this Vermisol drug is basically your levamisole, content also. It acts as an immune modulator, and it is given as 150 milligram OD per day for 4 days. This was a patient who was thought to be lichenoid reaction due to the gold crown, but the lesion has regressed, and when the treatment was done, so we were thinking that it may be a lichenoid reaction. Now the another patient where the local injections of Kenacort was also given. 40 milligram of triamcinolone acetonide was given once weekly for 3 weeks. Then along with this, 25 to 30 milligram of prednisolone was once daily given for 2 weeks, and prednisolone was tapered down to 5 milligram per day and stopped in 7 days. Now the same treatment was this I have taken from a journal, and they have also given the same treatment where we have added in our scenario tablet Folvide along with tacrolimus, and the tablet Folvide was given 5 milligram twice daily for 2 weeks. So as you can see, the lesions has regressed on the day 21, and the patient has a very good relief. Sometimes the laser treatment is also very useful when the low level laser therapy is given at 630 nanometers and delivering the 10 milliwatts of energy at 1.5 millijoules per centimeter square. So it can be used in the continuous mode and for 150 seconds, and patient also gets relief in such type of scenario. Of course, the healing period is actually takes time, but the procedure is painless. So next, coming to the oral submucous fibrosis. Oral submucous fibrosis, that's all we know that it affects the oral mucosa, the pharynx, and the upper third part of the esophagus. It is actually characterized by the fibroblastic changes in the submucosa, and the patient has the inability to eat and trismus, and the trismus is present. So the malignant transformation rate over this is OSMF to squamous cell carcinoma is 7.6 to 30%. This has a very high rate of transformation. The etiology being, we all know that is areca nut, which is the seed of the fruit of Areca catechu tree, and this is the etiology for OSMF. Deficiency disease, defective iron metabolism have all has been attributed to the etiology for oral submucous fibrosis. Usually, as we all know, the chewing habit varies from patient to patient. The buccal betel nut quid is basically placed in the buccal vestibule. It contains all kinds of gutka, pan masala, jarda, mawa, khara, khani, and the patient is wrapped it around in the betel leaf and put it in the vestibule. Now this actually causes the leaching out of this juice of areca nut causes the it causes the coarse fibers of this areca nut causes the mechanical irritation, and the juice which is the causes the chemical irritation is arecoline, arecadine, and guaiacine. They all causes the increase in the growth factor beta, and this ultimately causes your oral submucous fibrosis. So the lysyl oxidase is actually has been attributed to the formation of oral submucous fibrosis. So these can be taken. It's been there in any years of age. The person who is consuming the areca nut, he can be affected of oral submucous fibrosis. There may be a patient complaints of burning sensation. A patient may complain of blisters on the palate. There may be ulcerations due to the recurrent stomatitis. Patient may complain of excessive salivation. Now, sometimes patient is not able to swallow the food also, and when the fibrosis involves the larynx, the pain is referred to the ear. Sometimes there is a change in the tone of the voice due to the vocal cord involvement. So the hoarseness of the voice will also be there. Rarely, some patient complains of partial deafness due to the occlusion of eustachian tube. So these are the features for OSMF. As you can see in this picture, the lips are usually affected. There is a even slight reflection of this labial mucosa. You can see the blanched labial mucosa, and sometimes you can feel a circular band all around the mouth. So sometimes the uvula is also shrunken and giving rise to the hockey stick appearance. It appears like a small fibrous bud. Sometimes this uvula can get constructed to the one side due to the contracture of the musculus uvulus muscle. The fascial pillars become thick, extremely hard, short, and appears like a tent, as you can see in this picture. The tonsils may be pressed between the fibrous pillars. So these features can be seen in the very advanced form of oral submucous fibrosis. Some patient complaints of burning sensation, gustatory loss is there, and the tongue looks very anemic. This is the oral submucous fibrosis in the same patient affecting bilaterally on left and right buccal mucosa. It looks like atrophic. And as I have told you, that there is a transformation rate of 7.6% to 30%, leading to the squamous cell carcinoma. So the management per se is the same. Basically, you have to leave the habit. The first and foremost mainstay of the treatment is leave the habit. Otherwise, on the mild to moderate relief, we can always give dexamethasone 5 milligram injection in the period of 10 weeks. Sometimes the tablet of betamethasone can be asked the patient to dissolve it into 10 to 20 ml of water and then switch like a mouthwash. And the topical application of Kenacort ointment can also be done. This hyaluronidase enzyme is also very useful in this type of patient because it actually breaks down the hyaluronic acid, decreases the collagen formation, so thus the OSMF slightly decreases. Along with this hyaluronidase enzyme, we can always give the oral prednisolone, levamisole, as I have told you in lichen planus treatment also. So now the another modality we have seen, like it is a short exclusion diagnosis. We can feel the fibrotic bands, and we can say that it is oral submucous fibrosis. Why ultrasonography for buccal mucosa? It is basically, it demonstrates the number, it demonstrates the length and thickness of the fibrotic bands, and also sometimes it tells us the overall vascularity in the fibrotic lesion. Now, this is the on this slide you can see there is a normal buccal mucosa, and at the white arrow you can see the hyperechoic oral mucosal lining, and just lateral to the mucosa, that is up beneath the mucosa, you see that there is a some mucosa which is hypoechoic, and then there is a musculature layer which is probably a buccinator, which have a echogenic or isoechoic property. As we go more laterally towards outside, you will find the superficial muscles and the subcutaneous fat, and these are also hypoechoic in nature. So the in ultrasonography you can see the submucosa, and you can measure the thickness of the submucosa, how much it is affected by the oral submucous fibrosis. Another thing with the this ultrasonography, we can always combine color Doppler, and as you can see in this slide, uh, the first slide on the top left will show you the normal mucosa with uniform fine mottled appearance, interspersed with the hypoechoic areas due to the normal blood vessels and hyperechoic areas due to the fibers and nerves. On the top photograph, right side, you will see the color Doppler, which shows the speed and direction at which the RBCs approach and move away from the transducer, and thus it provides the information necessary for the functional duplex sonography, where we have given the red and blue color. Then when you come to the bottom left side, this shows the venous flow returns in veins, and it is shown by the continuous wave pattern, right? And on the right side, you will show the pulsatile wave nature. This will show the speed, the peak systolic speed of the blood in the oral mucosa. So here, what I want to portray here, that the ultrasonography along with the color Doppler will tell you the normal architecture of the buccal mucosa, how much is the blood flow in the buccal mucosa, is the blood flow is in the good is having the good velocity or not, is the velocity is hampered due to the fibrosis of the blood vessels also, and how much is the blood flow. So more the blood flow, more is the normal mucosa. Now if you can see in this patient has been given intralesional injection of the dexamethasone 4 milligram per ml along with the hyaluronidase enzyme twice a week for 8 weeks. On each visit, what we have done, we have given 1.5 ml of dexamethasone along with a 0.5 ml of hyaluronidase enzyme um, by the disposal syringe, and at each time we have given 0.2 ml in the buccal mucosa with with the 4 to 5 mm of distance from each prick. Now, when the ultrasonography was done, as you can see before treatment and after treatment, there is after the treatment there is a on the right side there is a good amount of vascularity present in the middle photograph if you see, and the peak systolic velocity of the blood was also very good. So we see that there is a good prognosis of this patient when this treatment schedule was given. Okay, so see, ultrasonography is not for the treatment. It is basically telling you that the treatment which we have given to the patient is in this patient the outcome is very good. Similarly, the pentoxifylline has been also been used in the medication for the oral submucous fibrosis, and it has been shown that the pentoxifylline acts as a rheologic modifier, because what happens in the oral submucous fibrosis, the peripheral blood vessels gets occluded, and because of the deposition of the collagen fibers and the hypercoagulability of the blood, it restricts the nutrients and therapeutic substances from reaching the affected tissue. So what we are doing with the pentoxifylline, it improves the macro circulation, decreases the blood viscosity, and improves the blood flow so that the peripheral tissue oxygenation is improved. So as you can see in the top photograph, the submucosal thickness was 1 millimeter, but after giving the pentoxifylline, it has reduced to 0.6 mm. So that means the hypoequacity also has been changed to hypoechoic. Similarly, in another patient, the submucosal thickness is reduced from 0.7 to 0.5. So the pentoxifylline is also a good game changer in oral submucous fibrosis. It actually increases the blood flow to the along with this pentoxifylline, you can give another nutrients also, like for example lycopene and vitamin C so that it gets deposited there. So the oral physiotherapy has also a good role. It such as the opening of and ballooning, opening of the mouth and ballooning of the mouth. This is thought to build up the pressure, and the laser treatment also been tried. This is from by one of my seniors who have tried the erbium chromium yttrium laser fibrotomy, and they have given the laser treatment to this patient. This has increased. They reported the increase in mouth opening of around 15 millimeter in a year. So this has a very good effect, and this is called as a thermal mechanical tissue ablation, which actually limits the amount of collagen damage. And after some time, when the patient is advised to do the mouth opening exercise also, it actually increases the opening of the mouth. Then coming to the leukoplakia, it is basically a white cancerous lesion. As we all know, it is predominantly white lesion of the oral mucosa that cannot be characterized by any other definable lesion except the use of tobacco. And they will also transfer into the cancer. The transformation rate is basically 0.1 to 17%. So the management of the leukoplakia involves non-surgical and surgical, where we all have been trying all the kinds of non-surgical interventions. The main is that the patient has been asked to quit the habit. As soon as he will quit the habit, he might get rid of leukoplakia. But patient should be explained that even if you have stopped the smoking, the leukoplakia patches may come after 3 years, after 2 3 years, because the circulation, the nicotinic acid which is in circulation with the blood vessels, they actually show their effects after sometimes after 2 to 3 years. So the non-surgical management includes vitamins, bleomycin, and photodynamic therapy. And surgical we can always do with a cryosurgery and the laser surgery. This patient, the patient was having the leukoplakia, and it can be, sometimes very difficult to distinguish this leukoplakia from the candidiasis. And in leukoplakia, we always found that it cannot be scraped off. So it is basically leukoplakia, and it can be uh, attributed to the patient's habit also, that patient is have a habit of smoking or not. This is the involving the tongue and the lower labial mucosa, and you can see the musculus. I'm sorry, you can see on the palate also. Typically, the presentation of smoker's palate or nicotina palatinae, where there is a uh, formation of the leukoplakia and over the palate, and the ducts of the minor salivary glands. Their orifices gets blocked, and patient usually complains that he is having the dry mouth. So it always affects, because the smoke which is coming out from the cigarette, which is coming out from the BD, is so extreme that it causes the dryness of the palate, and it causes the occlusion of the orifices of the minor salivary gland ducts. Sometimes these patients may have a leukoplakia, which is basically superadded with the candidiasis. So usually we should always involve the treatment of leukoplakia along with the antifungal treatment. And as you can see, there is a complete resolution with this antifungal treatment. Sometimes our haldi plays a very important role. The 3 capsules of curcumin, that is there is one capsule which comes at the name of BCM95, and it has been marketed in India and manufactured in India. 600 milligram twice daily. So 3 capsules, 600 milligram twice daily makes it around 3.6 gram per day, and that should be given for 6 months. This has also been shown to resolve the cases of leukoplakia. In this patient, vitamin A has been applied as a Dapibite cream, and the gel has been applied typically 4 times a day for 2 weeks. So there is a resolution of the lesion in the right buccal mucosa. Sometimes when they are present on the attached gingiva, this kind of treatment also works. Tretinoin ointment, acid gel is applied topically 4 times a day. One another variant of leukoplakia we have seen, like one of my ENT surgeon patient usually when comes with a complaint of vocal cord, the hoarseness of the voice. So we should always suspect the vocal cord dysfunction. The patient says that I have a foreign a sensation of the foreign body in the throat whenever I swallow the food. It looks like that something is stuck in my throat. So usually the video stroboscopy of the vocal cords, it actually provides the doctor with a slow motion magnified view of your vocal cords in action. So as you can see in this slide, there is a focal area of leukoplakia on the right vocal fold. So they should also be treated. Then coming to the hyperplastic candidiasis, previously I've told you that candidiasis and leukoplakia, they can be compared, they can be distinguished because the leukoplakia cannot be scraped off, candidiasis can be scraped off, leaving a raw erythema of, beneath it. But the hyperplastic candidiasis, the lesion appears as a white plug that cannot be rubbed off, and this is called as candidal leukoplakia. It is difficult to distinguish between both of them, even sometimes clinically and histopathologically. Basically, the main pathophysiology here is that the yeast cell, they actually forms a branching mycelium and gets deeper into the epithelial cell layers, and then they produce the nitrosamine, which is actually causes the development of the oral cancer, because the endogenous nitrosamine production is very harmful to the body. So in these kinds of cases, nystatin can be given, clotrimazole can be given. Clotrimazole comes in the form of gel, like Candid MP, which has come as marketed by, I think, Glenmark, and this is to be applied on the lesion for 4 to 5 times daily, uh, and for at least for 2 to 3 weeks. And amphotericin and tericin B, now it has actually, due to the mucormycosis in the present scenario due to the COVID, has not been available, but is a very good medication for the Candida albicans. Tablet fluconazole also can be given 200 milligram on the first day, followed by 100 milligram once daily for 2 weeks. Tablet posaconazole 400 milligram oral twice daily for 3 days, and then should be followed by 400 milligram orally once daily up to 28 days. Basically, what they are doing, the posaconazole, fluconazole, they actually inhibits the synthesis of ergosterol, that is the sterol component of the fungal cell membrane, and thus acts by inhibition of the enzyme, so that the candidal growth can be hampered. So this patient was treated with tablet fluconazole 100 milligram per day for 1 week. As you can see on the right, the lesion has healed. There were some plaques on the palate, and this was given tablet fluconazole 200 milligram on the first day, followed by 100 milligram once daily for 2 weeks. Then the patient with radiation therapy, yes, they also presents with the fungal infection. They usually develop the xerostomia also. So for xerostomia, you can always give the these your carboxymethyl cellulose and the artificial saliva. But usually the xerostomia after the post cancer usually resolves, but it resolves in a very slow manner. Sometimes the patient comes with a very gush of saliva, but thick. Sometimes patient complains with a xerostomia. But when these patients have a fungal attachment in the oral cavity due to the post radiation therapy, we can always give the fluconazole or tablet ketoconazole 400 milligram per day for 1 week. Then, second, lastly, we come into the actinic cheilitis, a very small thing. It's basically another pre-malignant epithelial lesion having the malignant potential, and it is directly related to the long-term sun exposure, and usually takes place in the fair complexion. But usually I have seen in the patients in Indian scenario also who are farmers, and it is also called as a farmer lip. Farmers who are exposed to the sunlight, continuous very strong UV light, and it is classically seen on the vermilion border of the lower lip, and as well as on the sun exposed area of the skin. And on the lip, it appears as a sometimes as a white plaque, maybe oval to linear in shape, measuring around 0.5 to 1 centimeter in size, and sometimes maybe crusted. When it takes the crusted form, you should be aware that it might convert into the squamous cell carcinoma, because the transformation rate is 10 to 15%. So in these type of cases, limiting the further sun exposure, applying the moisturizers, and staying hydrated reduces the symptoms of dryness. And there is one topical ointment by Glenmark Pharma. It is called as Imiquid 5%, which contains imicumod. This actually does very good wonders on such type of patient. This patient, the patient which you see on the slide has been treated by our fellow seniors. I think Madhu Krishna sir. They have done the partial vermiculectomy in this case. This is to show, this is not my patient, this is to show that how it can be treated. And furthermore, apart from vermiculectomy, basically laser ablation and cryotherapy can also be done. But what I'm telling you about the imicumod is basically it causes the, you know, it is thought to promote an immune response in the skin, leading to the apoptosis of the tumor cells. And then it causes the dermis to be invaded by macrophages, which leads to the epidermal erosion. So it somehow it promotes the immune memory and start taking our body start taking the immune system fast, and thus it reduces the crusting of the lip. Otherwise, we have to go for the surgical thing that as shown in this figure, vermiculectomy has been done. Lastly, coming to the Plummer-Benson syndrome, it is very rare because nowadays iron deficiency anemia can be treated as soon as they are visible. But some patients may go into the extreme cases of iron deficiency anemia, and this is called as the syndrophilic dysphagia also, where you have a post-cricoid dysphagia and upper esophageal web formation. It is associated with the high frequency of oral esophageal squamous cell carcinoma because it is considered as a pre-malignant process, and patient will always give a complaint that something is, there is a spasm in the throat or the food is sticking in the throat. This is the classical presentation of this Plummer-Benson syndrome. There's some angular cheilitis and diffuse papillary atrophy of the tongue. These two pictures I have taken from the net, where you can see the stricture in the esophagus, the barium while they have done the barium meal follow through, and this patient gives the some says that he's not able to drink the water, also not able to swallow the food. So the management, it is obviously a management through the physician. We can only refer the patient to the physician because it's a generalized condition, and patient has to be treated as a whole. So they usually give the dried ferrous sulfate, a tablet of 200 milligram of salt with the 60 milligram element of iron, and given 3 times daily for 3 to 6 months. And sometimes the dilation therapy is also done. So these are my references, and from which I have taken some help, and these are my cases. And I'm sorry, lastly, I wanted to tell you that diagnostic aids are also been helpful in these type of cases, where the visual examination is the first diagnosis. Because if you have seen various cases, if you have experience of various cases, the visual examination of lichen planus, the visual examination of leukoplakia, the proper history taking, the palpation of oral mucous fibrosis bands, the removal of the plaque from the from the white plaque from the oral cavity, leading to the thinking that it is a candidiasis. So these diagnostic aids are not further seen. The diagnostic aids help you in actually telling you that is it the lesion is benign or malignant. So in these type of cases, the brush biopsy is also done. Methylene blue staining is done. Brush biopsy is done, and then comes the one this veloscope instrument, which is actually is a handheld device, and it gives the visible light in a range of 400 to 500 nanometer wavelength. I have not personally used it, done only for 2 to 3 cases, where the main principle is that it actually gives the fluorescence. And for example, as you see in this photograph, that wherever the normal mucosa is present, it will give a very green apple hue kind of thing, and where the abnormal epithelial tissue is there and underlying stromal disruption is there, then the wavelength which will be reflected after falling on this abnormal cell, that is a dysplastic cells, will be different, and it will be a black in color, so that we can we are able to distinguish between the abnormal and the normal lesion, and then they can be biopsy. So these can also be used as a diagnostic aids. So with this, I finish my webinar. I am very thankful to Mr. Ruben Lobo of Dentist Channel Online, who has given me this opportunity to present this webinar. Thank you so much.
Well, thank you so much, Dr. Puneet, for all those wonderful insights and all that information that you've collected in almost 21 years of your practice. Putting that information in a presentation, I know is very difficult, but you've done an excellent job in putting whatever you could. Of course, I know
Yeah,
you need a lot of time to present all your views and all the information, all the
yeah.
wisdom that you.
There were so many patients' photograph were there, so that I can put. But it's a whole kind of library. I have accumulated so many patients' photograph whom I have treated, and so I thought I will present some patient's photograph.
Correct, correct, correct. I know, definitely yes. That tells us that we need to invite you soon to our platform to present many more webinars. Firstly, friends, we'd like to mention that in 2019, I suppose we met Dr. Puneet Bhargava, who was organizing one of the biggest conferences in India on corticobasal implantology.
Yeah,
We became very good friends with Dr. Puneet then. We saw the work that he's been doing, not just with patients, but the kind of management expertise he has. That is something that we were really astounded, and we were wondering how he's able to manage such a huge congress. That's when we understood that the kind of expertise that Dr. Puneet has, it's incredible, it's phenomenal, and we're really grateful to you, Dr. Puneet, for
thank you.
giving us this 1 hour of your time today. And Dentist Channel Online definitely hopes to having you for many more presentations on the topic, not on the topic, but on the discipline of oral medicine and radiology. Thank you so much, Dr. Puneet. Friends, before we move to the question and answer session, we'd like to request you to post all your questions in the question and answer box only. We'll be covering your questions shortly. Requesting you once again to post in all your questions in the question and answer box. That makes it easier for us to cover all your questions. For the ones who don't know Dentist Channel Online, I'd like to introduce Dentist Channel Online to you. Dentist Channel Online is a creative digital dental media company based in India. We cater exclusively to dentistry, right from dental events, workshops, courses, symposiums, congresses, etc. We've got everything in place for you. All you need to do is you need to save this number, get in touch with us, reply back with your full name. We'll add you to a broadcast list. That way, we can stay connected closely and we'll be able to give you all the information that you require as far as dentistry, international and national, both is concerned. All you need to do is save this number, reply back with your full name, and we'll add you to our broadcast list. Dentist Channel Online, in association with the Federal Dental Association from Germany, is organizing a series of dental online and on-site dental workshops, starting with a 10-day workshop on forensic odontology for the ones who aspire or who wish to get into the field of forensic science in odontology. For the ones who wish to know more about orthodontics in general practice, can be a part of this workshop, which is on orthodontics. This is an exclusive workshop for all those who wish to incorporate orthodontics in their general practice. This workshop will be taking place on June 5th and 6th of uh, uh, June 5th and 6th, which is about 5 days more. A masterclass on veneers, exclusive masterclass for the ones who wish to get into smile designs, aesthetic, cosmetic dentistry. This masterclass is a one-day masterclass, one full-day masterclass, which will be taking place from 9 a.m. to 6 p.m. An implant prosthetic workshop, an e-learning workshop, which is a two-day workshop, which will be taking place on June 26th and 27th. A workshop on implantology for beginners, and 8 module workshop exclusively for the ones who wish to get into oral implantology and implant dentistry. These are the sets of online workshops that Dentist Channel Online is organizing. This workshop is a 3-day intensive workshop on aesthetic dentistry for general practitioners. This is a hands-on workshop and on-site workshop that will be taking place in Bangalore. Another workshop, which would be a complete implant prosthodontics workshop, which is also a hands-on workshop, an intensive hands-on workshop, which also would be taking place in Bangalore. If you wish to be a part of these workshops, I urge you to get in touch with us. We'll be happy to give you all the details that you require for any of the workshops. Another feature of Dentist Channel Online is the Prime membership of Dentist Channel Online, wherein you can avail exclusive discounts on the aforementioned workshops, as well as on all the upcoming workshops that will be hosted to you by Dentist Channel Online. If you wish to be a part of a Prime member of Dentist Channel Online, log on to www.dentistchannel.online and register as a Prime member. Once again, requesting you friends to stay in touch with us. We'll be more than happy to stay in touch with you as well. For details on the upcoming webinars hosted by Dentist Channel Online, you are requested to visit events.dentistchannel.online. I repeat, events.dentistchannel.online. Thank you so much, Dr. Puneet. It's now time for the question and answer session. Before we move to the questions that we've received from our participants, I'd like to ask you a general question. Uh, a lot of people don't really look up to oral medicine and radiology as you know to pursue a PG. Uh, what according to you is the scope of getting into oral medicine and radiology, or what are the probable aspects that one can touch by doing a PG in oral medicine and radiology?
Um, Oral medicine radiology PG is basically, when I was BDS, I thought that I will do my post graduation in one of the subject of dentistry. When I actually saw that I am this oral medicine seat is available, I also thought that what I will do after doing oral medicine, I will go to the department and will see the patient, and if the patient is requires extraction, I will send it to the oral surgery. If the patient requires some filling, I will send it to conservative dentistry. If patient some requires some cleaning, I will send it to periodontology department. But the way of approaching to the diagnosis is very, very important. Now, what I have seen in my clinical practice is that the way I approached the patient when I was BDS, the way I approach the patient when I'm MDS, it's a hell lot of difference. The way of seeing it, the patient, uh, what is basically the diagnosis to the patient, because sometimes patient is confused. The pain is in the upper teeth or the lower teeth, because sometimes the patient is, it radiates like a river, and it's like, patient is not able to judge what is basically which tooth is paining. And if we say to the patient that this tooth is paining, and you get the treatment of this done, and suppose he comes tomorrow that you have taken out my wrong teeth, you have done my wrong tooth treatment. So the diagnosis is very important. So that's actually encouraged me, that because in the oral medicine, it is not actually oral medicine and radiology, it is oral medicine diagnosis and radiology, that is OMDR. So in the recent scenario, we are calling it as a oral medicine and radiology. The main thing is diagnosis, and this actually helps because you will take X-rays. And nowadays, due to the incoming of cone beam CT, there is a wonderful branch of dentistry where you can set up your separate diagnostic center, and you can see the images that nobody can see, the coronal section, the sagittal section, the axial sections, same as like we see in the CT scan. So and then treating all these patients, it is very, very difficult task. It is my personal opinion is that treating the patients of oral mucous fibrosis, lichen planus, leukoplakia, they are all very difficult, and the aphthous ulcer, they are all very difficult, and they are same as dermatologist who also usually gives a treatment, and the patient comes again and again, because these type of treatments are not permanently cured. So, but patient should have some kind of relief. If patient says that, if patient knows that he has a oral mucous fibrosis, he is not able to open the mouth. He is having a very, cheek which is very inflexible. He cannot whistle from his mouth. He cannot blow the air through the mouth. But he's also having those complaints are very, very timid. The complaint is burning sensation, complaint is not able to swallow the food. This is very important, and if you give some kind of medication and relieve these kind of symptoms of the patients, then it is a remarkable thing. So that's why the oral medicine is very important in our dentistry.
Thank you so much, Dr. Puneet. We move to the next question. We've got a question from Dr. Subramaniam. Doctor, can you tell us in brief about ultrasonographic technique? What is the difference between angular cheilitis and actinic cheilitis?
Okay, ultrasonic technique is, see what I have shown in my slide, that ultrasonography is not a treatment for oral mucous fibrosis. It is a diagnostic criteria, but diagnosis can also be made by palpating with the fingers. As we take the index finger in the buccal on the buccal mucosa, we can feel it like it is a belt, leather belt, and it is a very inflexible mucosa, very stiff mucosa. Why ultrasonography? ultrasonography actually will need you tell you the thickness of the submucosal fibrosis, the band, the thickness of the that fibrotic band. This will also tell you that if we do the oral submucous fibrosis of that I'm sorry, if you do the ultrasonography of that patient, it will tell you the vascularity of that mucosa. And if the vascularity is less, it is obviously confirmed that the blood vessels have been involved, and all those are involved, that the nutrients are not reaching it. So already the oral submucous fibrosis is an irreversible condition. It is very, very rare phenomena that if the patient comes in at the stage 1 of oral submucous fibrosis, then it is a time then you can reverse the condition. You can give the aggressive therapy to the patient, with the terms and condition that patient should also compliance, that he has left gutka, he have left eating the pan masala. And he's not eating the supari also. The main culprit is supari, that betel nut, the areca nut, which I have shown in the slide. So because sometimes what happens, patient says then, no, doctor sir, I am not eating pan masala, I am not eating jarda and all those, but just I am eating only a supari, 2 to 3 suparis per day. But he doesn't know that that is the main problem, that areca nut is the main problem, the betel nut is the main problem. So if he removes this habit, the condition will totally reverse. But when there is a stage OSMF 2 stage, 3 stage, it is very difficult to cure it. We can only do the medicinal part, that we can relieve him from the oral the burning sensation, the on having hot and spicy food, and the ulceration which are frequently taking place. Yeah, I agree that surgical management we can do. Laser therapy also leaves some scars, because one study I have shown, and there are so many studies, that in 1 year of time, when the laser therapy was given to the patient to the oral fibrosis, the average increase in the mouth opening is 15 millimeter. 15 millimeter is a good amount, I suppose, because the patient who is not able to open the mouth, and we give the opening of the mouth of 115 millimeter, that is good enough. But still, he will have some kind of fibrosis that time also. So it is very difficult to do, and it is irreversible. And another question of yours, that actinic cheilitis and actinic, I think, actinic cheilitis and
Angular and actinic.
cheilitis. Yeah, angular cheilitis is at the angle of the mouth. Like at the both side of the commissure of the mouth, you will have the angular cheilitis. Angular means at the angle of the mouth, where the upper lip and the lower lip are meeting with both the sides, and you will have a cut there. And why it happens? Sometimes it happens. You will see mostly in the those patients who are all right, but they have that they have a decreased vertical dimension. They don't have teeth in their mouth. Obviously, then they have to chew more. They have to bring. He has to bring the mandible to the maxilla excessively. He has to cover the more distance, and slowly, it will form the fissures at the angle of the mouth. Slowly the saliva will droop from those angle of the mouth, and that area will always be moistened. When this area will be always be moistened, there will be the fungal deposition on the angle of the mouth in that saliva, because the candida albicans is usually present in our the mouth, and then it will cause the inflammation of the continuous deposition of this candida albicans at the angle of the mouth in the moistened saliva. It will always cause a mycelium to grow, and ultimately it will cause the cheilitis, the inflammation of the lips. Actinic cheilitis is, actinic means the solar radiation. So it will be on the usually on the lower lip, because the lower lip is actually exposed to the direct sunlight. Upper lip, it's basically the vermilion border covers, and it will not be exposed. Upper lip is usually involved, and also the sun exposed area. So there is no so this is the difference between the actinic and angular cheilitis.
Thank you, doctor. Next question. What is the drug that is used in the treatment of xerostomia?
In xerostomia, treat the cause. Basically, treat the cause. If the patient is diabetic, there is a underlying, pathology going in the salivary gland, which we usually don't notice. And the SNR cells of salivary glands, they actually secrete the saliva. But when there is uncontrolled diabetes, usually the saliva gets reduced, the SNR cells get hypofunction, and the saliva will not be there, and patient will have xerostomia. Slight amount of patient will start comparing. Yeah, previously it was the saliva was in the good amount. Now there is a less saliva. So that is the xerostomia. And then if the patient is basically of coming from the cancer therapy or the post radiation therapy, he will also develop because the central X-ray beam of very high intensity has passed the salivary glands and then has entered into the mouth. So the salivary glands will also die. So what I'm telling you, first treat the cause. The cause is being treated, then obviously the saliva will come. Now for the saliva to come, we need some stimulant. Stimulant in cases of, we can ask the patient to take a vitamin C tablets. Nowadays, in the COVID scenario, also we are, prescribing Lim C to the patient 3 times daily. This will stimulate the saliva, and the saliva, so the patient will get relief of xerostomia. Sometimes OVAT spray. You can say one company has come with the OVAT spray, Dew Storm of ICPA. They are actually artificial saliva, and they, when you put into the mouth, they actually have a composition of carboxymethyl cellulose. They usually forms the saliva. You can take lemon slice also. You can take frequent 6 sips of water, because whenever there is a xerostomia dry mouth, you will not be able to swallow the food, because the food bolus requires some kind of saliva. Otherwise, dry food you cannot swallow. So saliva should be present there. And sometimes autoimmune disorders like Sjogren syndrome, Sika syndrome, they also lead to the uh, you know mm, uh, they also lead to the formation of saliva that is very less. So these are the conditions, and they can be, the medications can also be given. For example, the tablet Silagen, it is basically pilocarpine tablet, 5 milligram, I'm sorry, 10 milligram thrice daily. Then you can taper it for the another week. So these drugs can also be given. But first, treat the root cause. What is the cause for xerostomia?
Thank you, Dr. Puneet. With that, we come to the end of this wonderful evening we had, speaking so much about this nice topic, something that we really didn't tap Dentist Channel, to be very honest with you. It was nice that you introduced this topic to us and to our participants. Friends, thank you so much for your valuable time. We look forward to seeing you for all the upcoming
Because one
webinars
more
as well.
one more I wanted to tell you, Mr. Ruben, because these kind of problems are are there in every clinical scenario. And some kind of lesions like leukoplakia, lichen planus, they get undiagnosed. When I was BDS, I usually don't see the oral mucosa. I usually don't see the lip, the tongue, the undersurface of the tongue, the palate. I usually see what the patient asks, like, "Mere, I have a pain in this tooth, I have a pain in this tooth." But when we, tell the patient that you have a certain kind of lesion, he should be, aware of. Now, today is no tobacco day. Basically, my main motto is to give to the patients also. You usually say that you have a capability of stopping these habits. You have a, intense feeling that you can stop. Why not today? Because the single person is not getting affected. If he is having the, a cancer, the whole family gets affected, and everybody, have to run here and there to show the to he will show to another dentist. Somehow that dentist say that that is not a cancer. If he says that it is a cancer, he will go to another dentist, and they usually waste their time. Ultimately they go to the cancer institute, they will diagnose, and then the lymph nodes, and then the both sides of the lymph nodes get involved. Then they have to lose their whole of the jaw. So it's basically, our duty to explain to the patient in a very good manner, with a good counseling, that they should stop these habits.
Thank you, Doctor, so much. Thank you so much for all that time of yours. Friends, thank you for being a part of this session. Wishing you a very wonderful evening and a very nice evening. Thank you. Bye bye.